Selamat malam. Assalamualaikum warahmatullahi wabarakatuh. Ladies and gentlemen, we will start our webinar this evening. And together with us will join our outstanding guest from India, Dr. Abhay Falsafada, Dr. Shail Falsafada, Dr. Shaili Falsafada, Dr. Shamares from Jaipur. Malam ini kita akan berbicara mengenai surgical tips for all skill and experience levels. I will talk in mix in bahasa Indonesia, Indonesian language, and also in English. So first of all, I will ask Dr. Sharon as the medical director of KMN EyeCare to give his speech. Dr. Sharon, the time is yours.
Thank you, Dr. Hadi. Selamat malam kepada teman sejawat peserta webinar KMN EyeCare di seluruh Indonesia. Sebelum kita memulai acara ini, marilah kita bersyukur pada Tuhan Yang Maha Esa atas kesempatan yang diberikan dan semoga kita semua diberikan kesehatan oleh Tuhan Yang Maha Esa. Hari ini teman-teman KMN akan mempresentasikan sejumlah klip video pada berbagai situasi ketika melakukan operasi vakoemulsifikasi. Mudah-mudahan informasi ini akan bermanfaat bagi kita semua. Thank you to our guru, Dr. Vasavada, for agreeing to be on this panel. Dr. Vasavada is an old friend of myself and KMN cataract surgeons. Thank you also to Dr. Shail, Dr. Vaishali, and Dr. Samaresh for agreeing to share your experience in cataract surgery with all of us. Kami juga mengucapkan terima kasih yang sebesar-besarnya kepada Alcon sebagai sponsor utama, serta Cendo dan Sanbe sebagai sponsor pendamping dalam webinar kita hari ini. Terima kasih kepada teman-teman panelis yang telah mempersiapkan materi webinar ini, dan akhirnya kami juga menyampaikan terima kasih kepada seluruh sejawat peserta webinar. Selamat mengikuti. Terima kasih, dan waktu saya kembalikan kepada moderator.
Terima kasih, Dr. Sharon. Untuk menghemat waktu, saya akan segera memulai acara ini. Untuk itu kami berikan waktu kepada Dr. Victor untuk memperlihatkan videonya. Dr. Victor will show his videos on managing escape praxis. Silakan, Dr. Victor.
Terima kasih, Dr. Hadi sebagai moderator. Saya akan mulai dengan video pertama tentang CCC. Seperti kita ketahui bersama, CCC yang sempurna adalah kunci keberhasilan dalam vakoemulsifikasi. Saat ini dengan semakin meningkat pesatnya penggunaan premium IOL, CCC yang sempurna sangat diperlukan untuk menjamin kestabilan lensa intraokuler yang kita pasang. Ya, seperti kita tahu ada 4 kriteria CCC yang sempurna. Yang pertama harus sentral, continuous, sirkuler, dan dengan size yang tepat. Play video pertama. Pada video ini, terlihat adanya fibrosis di kapsul anterior, di mana terdapat kesulitan saat mencoba melewati area fibrosis dan mulai terjadi escape. Selanjutnya, dilakukan CCC dari area yang berlawanan. Ya, terlihat sisi dilakukan dari area yang berlawanan sampai ke area fibrosis lagi dengan menggunakan forceps. Flap kemudian ditarik ke arah sentral, tegak lurus tepi sisi sehingga tidak terjadi radial tear. Pada akhirnya kita akan menghasilkan CCC yang continuous. Cara lain yang bisa kita lakukan adalah dengan langsung memotong bagian atau daerah yang fibrosis dengan gunting. Kemudian kita melanjutkan CCC seperti biasa. Selanjutnya, play video kedua. Play. Pada video kedua, tampak operator memulai CCC dengan baik. Namun, saat melewati area main incision, terlihat bahwa CCC melebar ke area perifer, dicoba untuk ditarik ke sentral tetapi tidak berhasil. Kita sebaiknya tidak memaksa menariknya lebih lanjut karena akan mengakibatkan robekan meluas ke arah ekuator sampai kapsul posterior. Lakukan injeksi viskoelastik di area tersebut, kemudian flap dipotong dengan gunting, lanjutkan CCC sampai selesai. Selanjutnya, vakuemulsifikasi dilakukan dengan hati-hati dengan menggunakan low parameter. Selanjutnya, play video yang ketiga, play. Satu, dua, tiga. Argentinian flag, di mana terjadinya robekan pada kapsul anterior saat melakukan CCC pada intumescent white cataract, di mana robekan terjadi dengan sendirinya dengan tidak bisa kita kontrol. Umumnya terjadi pada white cataract yang mengkilap seperti mutiara. Hal ini terjadi karena tekanan intralentikuler yang tinggi akibat hyperhydration dari lens fibers. Biasanya tidak terjadi pada hypermatur atau katarak morgagni karena seluruh korteks sudah mencair dan tekanan intralentikuler sudah merata. Play video berikutnya. Play. Pada video ini terlihat setelah diwarnai dengan tripan blue, operator langsung melakukan initial puncture dengan sistotom yang sudah dibengkokkan. Akibatnya terjadi radial tear yang tidak bisa dikontrol atau tidak bisa kita hentikan. Ya. Video selanjutnya akan memperlihatkan bagaimana sebaiknya kita menangani CCC pada intumescent white cataract. Play video. Play. Ya, penggunaan tripan blue pada white cataract sangat membantu visualisasi kapsul anterior saat kita melakukan CCC. Gunakan kohesif OVD untuk mendatarkan permukaan kapsul anterior. Selanjutnya, lakukan initial puncture yang kecil dengan terlihat di sini dengan menggunakan jarum lurus. Jadi jangan sistotom yang sudah dibengkokkan. Kemudian langsung melakukan aspirasi massa korteks tanpa mengangkat tepi CCC. Kemudian lakukan CCC dengan utrata, lakukan dengan ukuran yang kecil, dilanjutkan dengan aspirasi korteks sebanyak mungkin, tujuannya untuk mengurangi tekanan di dalam lensa. Ya, terlihat massa korteks diaspirasi. Lebarkan CCC dengan size sesuai size yang diinginkan dengan menggunakan vanas atau forceps dengan membuat initial cut, tangan shell cut. Jangan lakukan sayatan tegak lurus karena dapat mengakibatkan radial tear. Ya. Demikian tips-tips untuk katarak white intumescent. Video selanjutnya. Play. Iris prolapse. Play.
Dr. Fikar.
Ya, dok.
Okay, let's talk on the. So I think those were some excellent videos that you showed, Dr. Victor, for the various kinds of problems that we may encounter during capsulorhexis. And I think the most important take-home pearl, 2 or 3 that I could we can take from these are: one is the importance of capsule staining, and capsule staining need not necessarily be only for a white cataract. Even for the first case where we did see that fibrotic plaque, sometimes with these dense cataracts, dense nuclear cataracts, or with dense cortical cataracts, the glow isn't very uniform in all directions. So it is always a good idea to stain the capsule with trypan blue whenever in the slightest of doubt. And staining also helps quite often in understanding the areas where the capsule is very thick, or the fibrotic plaque areas that we may see. So we may try and start the capsulorhexis from an area away from it, and try to size the capsular rhexis from the beginning in such a way that we can encompass that area of the plaque into the capsular rhexis. You could manage very well in bringing, going through the plaque area, but sometimes these plaques are so thick and so fibrotic, and they are already extending close to up to the equator. So in those cases, sometimes while trying to pull the plaque towards the center, it may actually rip off quite often. So it's a good idea that if while the slightest movement with the forceps, if you find that the forces required to pull this capsular rhexis are too large or too strong, it's a good idea to cut the capsular rhexis at that point of time with the scissors, which you very beautifully showed in the white cataract case. And I would also recommend the use of smaller micro incision rhexis forceps, so that we don't have to use the large main incision, because that leads to a lot of viscoelastic leak as well through that, which can actually lead to a split of the capsule before even your scissors can reach to cut the capsular fibrotic plaque. The second very important point that I learned from your wonderful videos is to have maneuverability of changing different instruments. So whenever in doubt, when you feel that the cystitome rhexis is sort of not going as per your control, it's a good idea to change to forceps, because forceps will allow you a more localized catch of the capsule, and it will allow you to control the size much better compared to a cystitome. So the two important principles to keep in mind are that if you want to pull in the rhexis, that is, if you want to reduce the size of the rhexis, you feel it's becoming too large or going to the periphery, pull towards the center with the forceps and pull up. So it is not just a two-dimensional movement of just pulling towards the center. It is centripetal movement along with antero-posterior movement. So pull to the center and up towards the corneal endothelium. That will help you to try and bring the capsular rhexis inside, or try and prevent it from running outside or extending to the equator. And I think the third important point that we all need to learn is the appropriate use of appropriate viscoelastics. So although we do understand the importance of dispersive viscoelastic and cohesive viscoelastic, for capsular rhexis, it is mainly the cohesive viscoelastic which is very important to be used. So cohesive viscoelastic is nothing but viscoelastics containing sodium hyaluronate. And it's important to know that these cohesive viscoelastics come in different concentrations of sodium hyaluronate. So higher the concentration of sodium hyaluronate, more heavy the viscoelastic is. So for a very mature cataract or a white cataract, we would want to use a sodium hyaluronate of a higher percentage. So the normal sodium hyaluronate that all of us are used to using off the shelf is at a concentration of 1%. There are higher concentrations like 1.4%, 1.6%, and even 2.2 and 2.5%. So in a white cataract, you want to make sure that you choose a cohesive viscoelastic with a higher concentration of sodium hyaluronate, because the aim is to flatten the anterior capsule. So I think these are three very important points that we learned from your wonderful case presentations of the capsular rhexis situations that all of us encounter at all stages of our cataract surgery training as well as practice. I would like to share some of our similar cases and what we find useful in salvaging such situations. At the outset, I do acknowledge that we do receive research grant support from Alcon Laboratories. This is one such case which is neither an extremely small pupil nor an extremely large pupil. And you can see the pseudo exfoliation margin all around. And what we have learned from experts all over the years, that in a small pupil, you can go right up to the edge of the iris to make a decent size rhexis. And sometimes with your proprioception, you can even go below the iris edge. Now notice here that while trying to go below the iris edge, we do find a little bit of difficulty, and we are not sure whether...
There's no video.
Sorry?
Video not seen.
Video is not. We see the video.
Is it visible now?
Yeah, visible now.
Yes, yes.
Yeah. So once the capsulorhexis goes below, we did the correct thing of trying to use the capsulorhexis forceps to pull it inside, but still we found that the capsulorhexis is not tugging in. So therefore, we felt that this capsulorhexis...
Sorry, sir. Video not play.
Yeah, the video has stopped. That video is over now. So we felt that...
Shell, the video is not playing.
Can you replay that?
Is it running, the video?
No, the video isn't running, Shell.
Is this video running?
No, this one is also not running. Try running it in the on a different mode. Try playing it here, clicking and playing here, see if it plays.
Is it?
Yeah, it's running
Yeah,
now.
yeah, we can view like this. There's no problem.
Yeah, absolutely. So what we are trying to do is we are trying to use the capsulorhexis forceps to pull it inside. However, we still found that it's probably going beyond the equator. So what we thought is that we'll need to convert this capsulorhexis from the other side. So the important thing is that whenever you feel the capsulorhexis is going out, try and complete it from the other side rather than from that same area. Inject heavy cohesive viscoelastic, and we created a nick in this area, and then we completed it from the other side and joined the area where it was lost. But still somehow the things didn't appear to be, going off very well, and we weren't sure whether we have been able to complete this capsulorhexis or not. And after putting the capsular hooks, what we found, if you notice here, this tongue-shaped extension, that the capsulorhexis is actually not gone up to the equator. It's staying right here, but it's just that because we did not see it well, we were fishing in, troubled waters. So I think it's important to make sure that you always do the capsulorhexis under visualization, and whenever required, do use iris retractors even in the middle of capsulorhexis. Another important point that we discuss is about capsule staining. And if you notice, this cataract appears very innocuous, an ideal grade 3 cataract, which we would all be looking forward to. And what you notice here is that the glow is reasonably good, and the surgeon feels confident that he should be able to do the rhexis in this glow. The surgeon is relatively hesitant in trying to create the nick. And if you can notice here, a little bit of lens matter has already been disturbed. Another important way to try and look for a good glow is to rotate the eyeball in different directions to try and get a better glow, but somehow the glow was just not good enough. And now, your heart starts beating faster. You are not sure whether a nick has been created, whether you are actually pushing the flap or not. And ultimately, you feel hesitant of moving forward or going ahead. So the simplest thing in such a situation would be to use capsular staining in such situations to make sure that you see well what you are doing. Another similar case of a small pupil, where on creating the nick and trying to do the capsulorhexis, what we did find is that the glow and the iris margin are not very much visible nicely, and therefore you inject fluid now below the viscoelastic, and following that you can actually even stain this capsule at this point of time to make sure that you see well, or the visibility is much better in such a situation. So we are first trying to inject or create a plane below the viscoelastic, and then injecting trypan blue below that plane of viscoelastic, which will help to stain that capsulorhexis and that will allow us. Now you can see, now the visualization is so much better, and the confidence of doing the capsulorhexis increases tremendously. So you can do capsule staining even in the middle of capsulorhexis. The trick is to try and inject the capsulorhexis below the plane of the viscoelastic. So create a fluid plane below the plane of viscoelastic, and then inject trypan blue below it, and it will stain the capsule reasonably well. Now, coming to capsulorhexis in a white cataract, apart from the wonderful points that Dr. Victor already showed, a couple of important points that are very, crucial to note is that you do need to make sure that you don't make the main incision at the beginning. So what we typically like to do is to just make paracentesis incisions. So even in this area of the main incision, what we have done is we've just made a small side port incision. We prefer putting an air bubble and injecting trypan blue below it. That allows for a more uniform staining of the capsule and prevents unnecessarily endothelial damage. And now what we are injecting is sodium hyaluronate of a very high concentration. Typically our preference is Helon 5, which is more 2.4% sodium hyaluronate. And again, like you notice, we are just making 3 side port incisions while making the capsulorhexis, so that the main incision is not made. Now, the other important trick is to use an unbent cystitome. Go inside, create a nick, and try to suck out some amount of cortical or liquid material that will help to reduce the pressure. And once again, we are using micro incision capsulorhexis forceps. Notice the incision is only 1 millimeter, and these forceps pass through anything from 0.9 to 1.2 millimeter incisions. So therefore, there is no leak of viscoelastic occurring whenever these movements of the capsulorhexis forceps are occurring. It's always important to stabilize the globe with the other hand, and based on how you feel, there is no compulsion to create a very large rhexis right from the beginning, because in trying to be very ambitious, sometimes you can end up extending even in the last clock hour or two. So once we realize that we are in reasonable control, we try and spiral out the rhexis to a reasonable size, and this should be sufficient to allow us safe lens removal. What you can also do in such a situation, when you feel that the rhexis has a very high chance of running out, is to first create a smaller anterior capsulorhexis, and then once the debulking is done, you can go ahead and create a slightly smaller, larger rhexis. So if you notice here, we aspirated some of the cortical material that will help to reduce the intralenticular pressure. And therefore, the chances of things running out are much less. Grasp and regrasp repeatedly. So I'm not trying to attempt to complete it in one go. Grasp and regrasp. And at this point of time, I felt this size is something that I was able to achieve safely. We did further debulking of the cortical material. Following that, now since I'm very confident that the intralenticular pressure is not high, I will go ahead and enlarge this capsulorhexis even before starting phacoemulsification, because doing phacoemulsification of a dense nucleus through a very small rhexis itself can be very challenging. So you can enlarge the capsulorhexis even before starting phacoemulsification. And this process can be done even after IOL implantation or after lens removal if you feel the capsulorhexis is too small in the end. So I think for a white cataract, the pearls that I would want to share is to use an unbent cystitome. Try to suck out some nuclear cortical liquid material to decompress the bag. Capsular staining. Do not make the main incision until the capsulorhexis is done. Use a heavy cohesive viscoelastic, and always there is no harm in doing an initial small capsulorhexis and a definitive large capsulorhexis after that. So thank you so much for the patient listening, and yeah.
Thank you, Dr. Shail. You have reminded us about some details that sometimes we ignore it, but it's very important in facing such kind of cataract like intermittent cataract, and also doing managing the rexis escape. So there are some questions. How can we calculate whether we can still doing phaco in the cases of Argentinian flag, which really tearing the capsule, intercapsule until the equator, and when do we have to convert it to extra caps? Maybe you can give some enlightenment in.
Absolutely, that's an excellent question. And I think if we are able to create some resemblance of a capsulorhexis, so for example, even if we have an Argentinian flag sign, it's a good idea to make a small snip with a with a small micro incision scissors, and try and convert on both sides of the Argentinian flag sign into some sort of a semicircular rhexis form of change in the anterior capsule. If we are able to do that, those pillars may be strong enough to allow us phacoemulsification through even that broken or Argentinian flag capsulorhexis. And the other notion that most of us have is that if there's an Argentinian flag sign, extracapsular may be safer, is not necessarily true, because in trying to prolapse that very large nucleus through an split anterior capsule itself is going to cause so much of stress when we try and tumble out that nucleus that itself can cause the tear to wrap around the posterior capsule and cause vitreous prolapse. So I think I would strongly urge to, resist that temptation of trying to convert to extracapsular or open surgery, so as to say, because if we follow the principles of trying to create some strong margin and use the principles of slow motion phaco, I think that would be a better, more reasonable option rather than converting into
Okay,
extra.
thank you. Okay.
I think the key, Hadi, the key
Yes.
is to use the low bottle height, and you can use as low as 20 centimeter bottle height, 30 centimeter bottle height, or whatever finds appropriate, and use as low flow rate as 14 cc flow rate, 18 cc flow rate, enough energy, more energy, and just sufficient vacuum. Do not hydrodissect that one, and convert it only and only when you really feel that you've done your best in the phacoemulsification. And if you're going to convert it, do not open the main incision before you deliver that nucleus into the anterior chamber. Like the manual SICS, in a closed chamber, whatever the incision you made, make sure that your nucleus is out from the bag into the anterior chamber. Then and then you enlarge the incision, and with visco delivery, just remove it with minimal pressure, close the eye, and then again see what is the situation.
Okay, thank you. So basically, we have to limit pressure inside the eyeball. So if we choose to continue the phaco, we need to minimize all the whatever the irrigation, aspiration, but still enough power to handle the nucleus. Okay, so I will ask Dr. Victor again to present the managing iris prolapse. We have some interesting video here, so we can learn it together. Dr. Victor, please.
Ya, video selanjutnya mengenai iris prolaps. Play. Ya. Di sini terlihat bahwa pada saat melakukan hidrodiseksi, terjadi iris prolaps dan secara spontan, biasanya kita akan mendorong masuk iris dengan kanula dan pada umumnya hal ini tidak akan berhasil. Kemudian terlihat di sini tampak bahwa injeksi viskoelastik yang berlebihan akan mendorong iris keluar dan sangat sulit untuk dimasukkan. Video ketiga memperlihatkan bahwa dengan terbukanya bibir luka akan membuka tunnel dan iris pun menjadi prolaps. Beberapa hal yang perlu diperhatikan untuk menghindari atau mengatasi iris prolaps. Pertama, buatlah tunnel yang cukup panjang. Kemudian kita hindari injeksi viskoelastik yang berlebihan. Kemudian kita mengurangi viskoelastik dari COA sebelum melakukan hidrodiseksi. Hindari mendorong iris masuk dari main incision, tetapi masukkan iris dengan cara kita menginjeksi viskoelastik tepat di atas iris yang dilakukan dari second port, atau menyapu iris dengan spatula dilakukan juga dari second port. Kita dapat menggunakan iris hook dan lakukan VECO dengan botol rendah dan low parameter. Pada tahap akhir, bila iris tetap prolaps, bisa dilakukan penjahitan pada main port dan kita membuat main incision yang baru. Kita lihat pada video selanjutnya bagaimana mengatasinya. Play. Video play. Terlihat di sini bahwa injeksi viskoelastik terlalu berlebihan, kemudian main incision juga sangat pendek, sehingga viskoelastik terus mengalir keluar. Ya. Operator terlihat berusaha menambah viskoelastik yang mengganti viskoelastik yang keluar, tapi malahan mendorong iris untuk prolaps dari main incision. Karena sebagian viskoelastik masuk ke bawah iris dan mendorong iris keluar. Lakukan sapu irisnya dengan menggunakan spatula iris dari second port. Terlihat bahwa iris tetap keluar pada saat kita mencoba CCC, dimasukkan lagi, dan akhirnya main port yang pendek kita jahit, kemudian membuat main port yang lebih baik. Ya, terlihat ini bekas jahitan pada main port. Lakukan buat main port yang lebih baik, dan selanjutnya kita dapat melakukan VECO dengan lebih aman. Ya, saya kira itu sekian video dari saya.
Thank you, Dr. Victor. Is there any comment from Dr. Samares or Dr. Fischel?
I think that's an excellent video demonstration of showing how important it is to understand how much to inject viscoelastics. And also another second very important learning point in that case was how beautifully the incision from where the iris was prolapsing was closed at a very early stage. If you try and persist with that same incision, the iris will constantly keep prolapsing through the incision at all different stages. And by the time you're actually in the important stage of chopping or nucleus removal, the situation becomes very, very difficult to handle. So it's better to accept that fact that it's not the best situation occurring through this incision and make a new fresh incision. Another important point to note is the length of the incision is also very important. So if the distance between the external incision and the internal incision is very short, the chances of iris prolapse occurring are quite high. So you need a good length of incision at the distance between the external incision at the limbus and the internal incision inside the cornea should be at least 2/3 the length of your external incision. Say, for example, if your external incision is about 2.2 millimeters, the distance between the internal incision and the external incision should be at least 1.8 to 2 millimeters in length. So you need ideally a perfect square, but at least a two-third gap between the external and the internal incision to make sure that the valvular function of the incision works well. But I think that's an excellent video presentation that you have shown. Dr. Vaishali or Dr. Samresh, any suggestions or comments from your side?
I think
Yeah, I think the audio is hung up. So we'll be sharing some of our similar sort of situations where we find what things that we find useful.
why can't you talk like a normal person? Okay.
So Samresh, is the video running in this format?
Can you try playing it? Well,
Yes,
it's running.
It is now.
Yeah. So if you notice here,
Yes.
please note that I'll just restart the video. So this is a case, innocuous looking, well dilated pupil case. Keep an eye here on the area of the side port. So if you notice here, you see the shape of the pupil. It's slowly and slowly turning a little bit oval. The parameters are not very high, 40 IOP, which is equivalent to a bottle height of about 57 to 60 centimeters of bottle height. But slowly and steadily, the shape of the pupil is more and more becoming oval. And now there is a frank abutting of the iris to the chopper. So at this point of time, it's very tempting to pull out the chopper and reposit the iris through the same incision, but that is a temptation that we must all avoid. And what we find useful in such a situation is to stop. Notice here now we have gone to foot position 0. That is stop the infusion, because what has led to this is excessive fluid going behind the iris. So go to foot position 0. Now we have dropped our bottle height even further. So from 40 IOP, we have come down to 30 IOP. So from a bottle height of about 60 to 70, we have come down even further to about 40 to 50 bottle height. And notice now, once that is done, and then we'll go back again to foot position 1, the iris has again gone back automatically without actually having to use any instrument to push it back. And all through the lens removal, now there will be no further abutting of the iris coming to the side port, and we could prevent this situation from going out of hand. So I think early recognition is very important, and if you recognize early, the most important step to do is lower the parameters that you are already using. So if you are using from the beginning low parameters, go even lower. So whatever the parameters are, go lower than that, and you'll prevent this from going out of hand. So use lower parameters as far as floppy iris goes. A similar case to what Dr. Victor showed, very obese, hypertensive, diabetic, and heavy breather. And like over injection of viscoelastic can cause the iris to prolapse, similarly over hydrodissection or excessive fluid injection can do the same. So the hydrodissection was done, but unnecessarily excess of fluid is being injected. And notice here, if you notice, there was a touch of the cannula with the to the iris, and that itself is sometimes sufficient to cause an iris prolapse. So the iris has already started prolapsing here to the main incision. The other mistake is to inject cohesive viscoelastic. So this is the time when you don't want to inject cohesive viscoelastic, which as shown beautifully can go below the iris and cause it to prolapse further. And the third is to try and avoid repositing the iris with a metal instrument, because what this does is it causes lot of iris trauma and lot of pigment release. So the easier or the more appropriate thing to do in such a situation would be to approach the iris prolapse from an area other than the main incision. So don't try and inject viscoelastic from this area, approach it from the other side and inject a dispersive viscoelastic. And why a dispersive viscoelastic? Because dispersive viscoelastic, like Viscoat, is a retentive viscoelastic, that is, it will stay there. A cohesive viscoelastic can come out as a bolus. And this procedure can be done even before starting IA. For example, in this case, we found that the iris is coming close to the main incision. So go ahead with the viscoat and inject it over the area. So that will flatten it and that will make sure that the iris behaves properly now then on. Another important time when you want to inject dispersive viscoelastic is when you are using iris retractors, because sometimes due to the pull of the iris retractors, the iris tends to tent up. And particularly while injecting the IOL, this can cause a lot of problems. So inject dispersive viscoelastic over the main incision from where you are going to inject the IOL, so that the iris doesn't prolapse or doesn't keep coming up and hitting the IOL. So I think it's important never to reposit the iris through the same incision. Avoid using metal instruments and use a dispersive viscoelastic so that it makes sure that the iris remains there as it is. Another important thing that we keep coming across quite often is that the pupil keeps becoming smaller and smaller as the case goes on. So good trick is to stop the procedure and inject diluted preservative-free adrenaline. And more often than not, this works very well if the pupil has originally dilated well, and it dilates sufficiently large that you are able to go ahead and complete your procedure. So don't hesitate to inject diluted adrenaline at any point of time. For example, here we found that we were able to place the IOL well, but it was a trifocal toric, a panoptic toric, and we wanted to make sure that we align the IOL perfectly. Here we couldn't see the dots of the toric IOL, but before doing irrigation aspiration, we just injected diluted preservative-free adrenaline and the pupil dilates beautifully, and now we are able to see the dots well, so that we can align this IOL into its perfect position at the end of surgery. So another important pearl is to use intracameral diluted preservative-free adrenaline at any stage of the surgery. And the final point that I would like to make is that there will be times when, in spite of adrenaline, in spite of all your efforts of bimanual irrigation aspiration, uh, you may be in a situation where you are not able to see very well, and you end up with cortical fibers, as in this case, where in spite of all efforts of trying to occlude below the iris, we were just unable to catch this epinuclear plate that was hidden behind the iris, and we were struggling to no end. This is an edited video, but we struggled for minutes. So the take-home message here in such a situation is that there is no restriction to the time at which you can use iris retractors. So although this was the last step of surgery remaining, cortex removal only in one quadrant was remaining. But because we weren't able to see, and because we weren't able to do it under visualization, we were struggling. Once we put the iris retractors, we were now able to see much better. We were able to see that there was an anterior cortical bunch which we could occlude and then remove it. So it's important to keep in mind that you can use iris retractors at any stage, and intraoperatively, if any pupil expansion device is to be used, I think it's safer to use iris hooks, because even if by chance you grab the capsule, you anyway do that, use these iris retractors for subluxated cataract management to hook the capsular bag. So I think achieving adequate exposure, make sure you prevent iris trauma and prevent intraoperative miosis, and fluidic parameters are very important in managing a small pupil intraoperatively or floppy iris.
I just want to. I want to add one point here. Can you hear me?
Yes.
Yes, we can.
I think one very important thing is to anticipate. So anybody who is taking a prostate medicine or long-standing diabetes or even a glaucoma patient, we must think that this patient might have a floppy iris. So your OT assistants should be ready with viscoat and adrenaline and iris hooks. And you should have a separate setting called floppy iris. You can put those parameters in your machine and save it as floppy iris. So every time there is such a case, you can use those parameters rather than the normal parameters.
Thank you. And I think also in cases such as floppy iris, during the surgery, I think we have to, as maximum as we can, to avoid to touch the iris, because touching the iris will induce the meiosis. And it is quite surprising for me that adrenaline is still working in such cases. Thank you.
No, well, Dr. Hadi,
Yes.
can I take your permission now to introduce
Yes.
a speaker, which I'm very proud to introduce. She is Dr. Viraj, my other daughter, who developed, unfortunately, intracranial hemorrhage 2 years ago and was on a ventilator for 2 weeks, but thank God survived, and she has come out quite well, fighting a right-sided hemiparesis and aphasia. So she has innovated a technique of cortical removal, and she called it whatever she called it. So you please listen, Dr. Viraj, and go ahead with your presentation.
Hi, Viraj.
Welcome.
Go welcome.
How are
Please.
you? All of
I
them.
am.
Hi.
Hi.
So
Hi, Viraj.
happy. Hi, Victor. How are you all? I am back again. And
Okay.
Chakon, Hadi, and Victor, so on. My friends, I am still on. And thank you for presenting my case. Thank you. So, change topic. Now, yes. 1 minute. Yeah. Pop's technique. Pop's technique is, I am proud.
The video yet.
We can't
Yeah.
see you.
We cannot see the video. Aditya, you'll have to share the screen.
Kidding.
Sharing the screen. Okay.
One minute, huh? Please.
Can you see?
Yes, yes.
Yes or no?
Yes, yes, we can see.
Yes, okay. Pop's technique. My technique also say now posterior
Position.
Position. Gently but firmly, I am able to hold and importing to catch,
Complete occlusion.
occlude fibers and occlude. So hold it, occlude, and then posterior detachment is so important.
Cortex down.
Pulling cortex under rexis and hold it, sort of say. LECs and fibers both must remove. Swiping. Then simple, but swiping is necessary. So hold and detach and hold, swipe basically. And then finally separate. Simple technique, but I love Pop's technique. That's why demonstrate for you. Now, another example. See, Pop's technique, conventional radial pull. But notice, fibers is removed, but little fibers is left. So, conventional radiation method is well, but Pop's technique is superior. I feel that. So, cortical removal, LECs, fibers, all of them, and then clean back. So slowly, but clean cortex all over. Small point, but I thought share with you. Yeah.
Thank you, Viraj. Excellent.
Thank you. Excellent.
And Hadi, thank you for presenting me, please. I am happy to be part of your part. And adios, my friends. Bye bye. So on.
Bye-bye. Thank you.
Thank you. Thank you.
Bye.
Happy
Thank
you
you.
are
Thank
with us
Thank
this evening.
you.
I think
Thank you.
what Viraj said, I just make sure that our friends across understand. Instead of a radial pull, which most of us do, we put the aspiration probe in the cortex and pull it and pedal down, high vacuum, it goes off, and it works very well. Sometimes you leave behind the equatorial cells, residual fibers, so go slow, position your aspiration port, occlude it, detach it, or displace that occluded port toward the posterior capsule, and then swipe. That will remove the fibers completely and also will reduce the stress on the zonule. So thank you, Viraj. Yeah.
Thank you.
Okay, thank you. I think we have to continue our schedule now, and Dr. Ricky will talk on the PCR, how to prevent and handle it. Dr. Ricky, please.
Oke, terima kasih Dr. Hadi. Oke, saya akan bicarakan mengenai posterior capsule rupture.
Suaranya nggak kurang keras.
Oke, bisa kedengaran dok? Bisa?
Ya.
Ya, bisa.
Halo.
Oke.
Oke, saya akan bicarakan pada video berikut ini mengenai posterior capsule rupture, mana dalam video ini didiskusikan tentang sebetulnya mengenali tanda awal dari ancaman PCR dan bagaimana mengatasinya bila itu terjadi. Video. Pada saat ini waktu kita grooving, perhatikan sebetulnya kedalaman dan kejauhan dari trench yang kita buat. Pada kasus ini dugaannya terjadi saat terjadi grooving yang agak kedalaman dan kejauhan, tetapi pada saat itu belum disadari juga tidak terlihat dengan baik. Namun saat rotasi, kita terasa agak seret dikit dan kelihatannya sedikit dipaksakan. Sangat besar kemungkinan bahwa situasi inilah yang memperbesar robekan tersebut. Saat terlihat ada bolong dan robekan itu, ya segera posisikan pedal pada posisi 1. Jangan lupa, langsung kembali pada posisi 1. Jangan tiba-tiba dikeluarkan vekotipnya. Tetap pertahankan posisi pedal pada posisi 1 dan masukkan OVD. Nah, injek secukupnya pada daerah yang robek agar vitreous itu tidak naik ke atas. Nah, pada saat ini pedal boleh pada posisi 0 atau handpiece-nya juga boleh dikeluarkan. Namun secepatnya atur parameter dilakukan sampai pada low parameter dan lanjutkan lagi dengan memperhatikan hal-hal yang berikut, yaitu lakukan inject OVD yang berulang secara adekuat. Namun jangan lupa setiap kali kita memasukkan atau mengeluarkan vekotip maupun tipnya, maka kita harus duluan keluar itu vekotipnya itu, kemudian baru sementara kita mengeluarkan itu, kanul yang berisi OVD itu kita tarik pelan-pelan dan itu yang paling belakang keluar. Nah, kalau kita lihat di sini, apabila robekannya kecil dan stabil, sebetulnya bisa masukkan lensa itu di dalam lembek. Tapi kalau kita meragukan dan robekan itu agak besar, ya usahakan kita pakai tripis ya, kita pakai tripis dalam ini. Dan kalau seandainya untuk melakukan tindakan yang lain itu sebagai pilihan kita lakukan iris clip atau scleral fixation pada tahap selanjutnya. Namun untuk memastikan seperti yang kita lihat pada film ini, bahwa untuk memastikan ada vitreous di depan, maka kita berikan pewarnaan dengan pemberian triamcinolone dan lakukan vitrectomy anterior sampai terlihat bersih. Dan sangat dianjurkan untuk menjaga kestabilan COA dengan menutup luka insisi secara sempurna, bahkan pastikan dengan menambahkan 1 jahitan untuk sebagai pengaman. Oke, thank you.
Ada video lagi Dr. Ricky atau hanya satu?
Oh, kayaknya sih. Coba ada video lanjut itu bagaimana sebetulnya untuk melakukan menghandle kalau seandainya hal-hal yang bisa kita prevent.
Silakan.
Berikut film videonya lanjut aja. Oke, dalam video ini kita lihat sebetulnya untuk hal-hal yang sebetulnya kecil yang sebetulnya kita bisa prevent, ya mungkin beberapa hal yang bisa terjadi pada saat waktu kita melakukan VECO pertama itu di mana mungkin VECO-nya keras sehingga kita capek, tapi pada akhirnya justru yang sudah tinggal kecil, maka terjadi hal yang tidak kita inginkan. Nah, untuk itu apabila ini terjadi, maka jangan lupa kita lakukan bahwa perhatikan bahwa pada bagian akhir atau fragmen terakhir itu selalu ya saya ingatkan kembali itu parameternya diturunkan, dan kalau seandainya memungkinkan itu bisa lakukan proteksi bagian posterior dengan kanula atau spatula atau apapun yang bisa kita lakukan, tapi sebaiknya dengan memproteksi dengan memberikan injeksi viscot di belakang untuk memperbesar space yang di belakang supaya apa yang kita lakukan di anterior itu terhindar atau berada jauh dari di belakang yang ada kapsul posterior yang tanpa sadar kita bisa kissing efek dari itu sehingga terjadi robek. Oke, terima kasih.
Terima kasih Dr. Ricky. Any comment from Dr.
Samresh,
Yes.
Vaishali, any comments? Otherwise, I will make a talk on that now.
Let's go ahead with the talk.
Okay. I wish Shakon is there to help me in this presentation. And Shakon, I would value your comments during or afterwards.
Thank you, Dr. Basavada.
At the outset, I want to recognize the teaching of Dr. Steve Charles, with whom I do with whom we do this course at ASCRS. And why did he call coming up here? And my colleague, Dr. Deepak Bhojwani, who is our retinal consultant, who has been helping me and giving me useful tips. But everybody is so familiar with this situation when the posterior capsule ruptures. And these were olden days where I would react this way. I'm very happy to say that I don't have that situation anymore now, because I think I realized that the road I was taking, I need to change. So I'm now suggesting you to take the path that I never took for many years in my cataract surgery. So when the posterior capsule rupture, first thing, irrespective of how we are going to perform vitrectomy, do not panic, keep calm. And then first thing is to inject Viscoat, which is a dispersive viscoelastic with chondroitin sulfate, which will act as a barrier to that vitreous which is prolapsing. And once you do that, then and then you retract the instrument, phaco probe or IA probe, whatever you have. And then next step would be to assess the extent of the PCR if you can. Identify is there a vitreous prolapsing through that rupture, and tell your theater staff to have scleral fixation IOL, 3-piece ciliary fixated IOL, and whatever you have. Keep it ready, and that you must have always a 3-piece IOL and a scleral fixated IOL as a backup for all the cases you do. So we have our company giving us a 3-piece every time we order a single piece in case, and we return that 3-piece IOL back to them next day. So always prepare and have a backup of 3-piece. But assessing the PCR, its extent, we need to understand the area and rotate the globe and see how big is the rupture, what is the extent of the lens material. And the best thing is to triamcinolone preservative-free. We use Orocort, Indian-made, but you can have Triasens and whatever else you can use. And then do that. The current method, what we do is this, that we inject triamcinolone. This is the same video you saw initially, and make sure that we identify the extent, and then this is the step, which Shakon I learned a lot whenever I was in KMN, and I produced sufficient rupture there. So classically, a 3.5 millimeter incision, but first thing is to go transconjunctivally under the conjunctiva over the sclera, not perforating the sclera, under the conjunctiva, and then turn the trocar 90 degree. It's a 2 incisions that are separated, 2 punctures, and then notice it, that vitreous in the chamber is simply drained into the vitrector port without disturbing that rupture area. So that's the beauty of this pars plana approach. The irrigation is in the front. So there is only 1 port into the pars plana. You can make 2 port also irrigation, but for most of us, the cataract surgeon, irrigation through the limbal paracentesis and the vitrectomy to the scleral, 3.5 millimeter away. And now this eye will behave as if there is no rupture because there is no vitreous in the area of our action. And therefore, without any scaffold, artificial scaffold, or any fear of lens dropping, I'm continuing with the lens removal. And notice the flow rate now is the lowest possible, 12 cc per minute. But sufficient energy and sufficient vacuum. And I'm able to do it without fearing that lens material going down because there is no vitreous and I'm not attracting that vitreous through that tear, so that I'm able to remove without any scaffold all the materials I could. Now, the reason you should not fish out a sinking fragment is this. There is an anterior capsule split here, and with the maneuvers and with the gymnastic I'm doing, that is getting extended over the equator here, and the material is just sitting there in the antivitreous. It's very easy, it's very tempting to remove it, posterior levitation, anterior levitation, and see the vitreous tracks. The anatomy of vitreous is such that it really produces the effect on the base, on the central retina, and sometimes you initiate a giant tear. So although you're looking here, you have no idea what's happening to the interface of that. So do not do this. Never, never introduce an instrument to remove that fragment which is within your reach. You think it's within the reach. Instead, let it go there. I call it a bye-bye technique. Just leave it alone and perform sufficient anti-vitrectomy whichever way you want to, and place the lens in the support and let the KMN retinal surgeons or any other retinal surgeon handle this at same time or next day. My colleague, Dr. Deepak, has given me this video to demonstrate why we should not levitate or fish around. This lens material is wrapped around by the vitreous. So if you try to bring that, see that what I was meaning? This is the vitreous tracks, this vitreous wrapping around. And if you try to remove it with Vactis or with any levitation, you can understand that you will produce a havoc in the vitreoretinal interface. So never, never do that. Instead, let it go, and the vitreous surgeons will then remove it later on. So what is our goal? Is it to remove this sinking lens material or to avoid a drop of the nucleus? No, that is what I thought for years. Our aim is not to salvage the sinking material or to avoid lens drop, our aim should be, and as I learned from Chacon and many other retinal colleagues, is to prevent an acute, on-the-spot, intraoperative vitreoretinal traction. And then do it in such a way that you remove the vitreous adequately and prevent further enlargement of the rupture, because we want to put the lens in the bag if possible. And wherever you put the lens, create a symmetrical, uniform support of the IOL by doing sufficient vitrectomy. So let's understand that. But before you do that, please, and I still recognize my colleagues, Deepak's and many others, retinal colleagues, telling me to avoid hypotony during the vitrectomy, whatever way you're doing. Never perform the dry vitrectomy, and please avoid swabs and the scissors vitrectomy through the open sky. So now we need to decide which way you want to do, the limbal or the pars plana. This is very familiar, and you saw a wonderful way of managing a limbal vitrectomy, and I've done it for years. But make sure that you go into the incision and remove that, because there is a lot of peaking of the pupil later on, and use triamcinolone all the time. But I thank Dr. Samaresh, who really taught me what happens when you do limbal vitrectomy. This is imagine this is a posterior capsule rupture, and you are doing a top-down vitrectomy. The vitrectomy is here, and you're removing the vitreous, even with triamcinolone and whatever you do. What happens is that there is a drag on the vitreous body, which is behind the PCR, and invariably this rupture enlarges. So this is so familiar to us as a cataract surgeon. You start with a small PCR, but the moment you do vitrectomy through limbal, the PCR enlarges, and many times we are not able to put the lens in the bag, which is a defeat for a cataract surgeon. So although the limbal approach is very familiar for all of us and has become a routine, and it was a routine for me for many, many years, I think we should understand, first thing, that it really causes the drag and therefore intraoperative vitreoretinal traction much more through this top-down limbal approach. And typically it enlarges the rupture and enable to put the lens in the bag. On the other hand, I'm showing you the video which you want to assess the rupture well, and having done that, you can then I'm showing the same video again, just to emphasize the importance of the single pars plana entry vitrectomy for a cataract surgeon. It may sound intimidating. I've never done pars plana. How can a cataract surgeon do it? It's not difficult. Instead of a limbal approach here, vitrectomy, you just go 3.5 millimeter away. Aim to enter the center of the globe and not the center of the pupil, and have a 2-inch puncture separated out, as I told you earlier, and then irrigation in front, and then you see that vitreous simply disappears without any turbulence and without any effect. So that's what I showed you. But once again, Shamresh educated us why the tear doesn't enlarge. And this is what happened. You saw that clinical case, the vitreous being drained, and he showed this with beautiful wool experiment, that that vitreous, which was in the anterior chamber, is being drained into the vitrector without any extension. And therefore, pars plana approach is good. It reduces the vitreoretinal traction and the consequences of it. But difficulty is that I've never done it. It's unfamiliar. How can I do as a cataract surgeon? You don't need an elaborate setup and technology. What you need is to see a video, understand and talk, interact with your vitreous retinal surgeons in KMN and learn from them. So once again, Shamresh did a high-speed photography, which he published in JCRS, and he illustrates how the limbal vitrectomy, at the moment, the irrigation and vitrectomy. Both are through the limbal incision. And notice the turbulence that it creates when you do this top-down approach, and the tear is really will enlarge. And once the vitreous is dragged upwards, you can see that turbulence even more, and invariably the tear extends. Now, when he showed us to the pars plana, here the vitrectomy is to the pars plana, irrigation is in the front, and you notice that there is less turbulence, and the tear will not enlarge at all. So where would you introduce? This is simple anatomy that you want to understand. Somewhere beyond pars plicatum, anywhere 2 millimeter plus, younger the child or a child 2 millimeter plus, but otherwise 3.5. And you can measure, you can do sclerotomy. You don't need a trocar. A trocar has a disadvantage that it will need a good pressure in the eye. If the IOP in the eye is not very much, this needs more force to enter into the eye. So make sure your incisions are sutured well or watertight, and then take your time to introduce. And then once you do the vitrectomy, you will see the same effect, that vitreous in the antechamber, it goes around the equator and it is being sucked in. So once you remove this vitrector at the end, and I learned from this Dr. Manish Nagpal that you use an instrument to make sure that you dent the entry at the same time, and make sure it will reduce the incarceration of the vitreous. So you don't need a trocar, by the way. You can have any sharp knife, a paracentesis knife or a lens knife, do a peritomy and measure the incision 3.5 millimeter away, and then you can introduce. This is the paracentesis knife that I had to do a sclerotomy, but at the end of that, make sure that you suture it well. So how does a vitrector work? You can have a two-mode, irrigation, cut, and then aspiration, or irrigation, aspiration, and then cut. The best way and the safer way to reduce the pulsatile traction is to use this mode: irrigation, vitrector, and then aspiration. And that's what is the default. And all the vitrector machines, vitrector probe in any machine you have will have that capability. And finally, we want a stable IOL. So what is that support of the IOL? We always have felt that it is only the capsule which supports, but it is the entire anterior vitreous phase that supports the IOL eventually. So understand that you need to have that support very symmetrical, otherwise there will be a tilt. And this is what happens when you do limbal vitrectomy. It is very difficult ergonomically to have an access to all the parts. So you leave behind the pockets of vitreous here. So even if your lens is placed and you think a patient will be happy, patient will complain of poor quality vision, and that's because there is a tilt. The vitreous is not supporting symmetrically. There is an asymmetrical support. Instead, if you go limbal one vitrectomy, you can understand ergonomically, you can produce a better symmetrical removal of the vitreous, and therefore the chance of IOL tilt or unstable IOL will be reduced. And once again, Shamresh comes to rescue us, and he showed beautifully, he's an expert on Miyake view, showed how you leave behind vitreous pockets, and you can see these vitreous pockets here when you do limbal. But when you do pars plana, you without any extra efforts can remove this vitreous very easily and create a symmetrical scaffold. And in reality, even if you're done vitrectomy, make sure that you take your more time. You can never overdo doing vitrectomy, and remove the vitreous from the area of the optic, underlying the area of the optic, so that there is no vitreous pockets left behind. Remember to assess it with the retinal colleagues for every eventuality, if possible on the same day or on the next day. What are the parameters? Sufficient IOP, 30 to 40 centimeter IOP, that means about 50 to 60 centimeter bottle height, with the peristaltic system of a phaco machine, 10 or 15 cc per minute, not more, because you want vitreous to come to that port when the port is open, and sufficient vacuum of 300, 400 or whatever. If there is a lens material, you can have a higher vacuum, but flow rate should not be more than 15 cc, because you don't want to aspirate it very fast. You want to cut it first. So low aspiration, but sufficient cut rate. Highest cut rates you have in your machine. Usually, most of the cataract machines will have 4,000 cut rates, but some machine will have 5,000. So finally, how do I do this? You need to change your mindset. Believe this in this concept. And I need some comments from Shakon. Change your mindset. Learn from your colleagues. So finally, I'm very happy to see all over the globe, I think more and more people are taking this path which is less traveled, and now many of us have understood and are beginning to join the path which was never taken before. And by the way, this is for your information, our father of nation, Mahatma Gandhi, who took this path for all of us on a different objective. So thank you for your patient hearing. Thank you.
Thank you, Dr. Basavada.
Shakon, what is your take-home tips to the colleagues in Indonesia and on all over? And please have some comments from you.
Yes, Dr. Basavada, you did a one-year fellowship in retina, didn't you, in England?
Well, don't tell anybody, sir.
So I think those pointers about avoiding traction on the vitreous are extremely important. Regarding doing the pars plana vitrectomy, if there is no retina surgeon, it's possible to do it, but I think it's not enough just doing a video. It would have to be at one of our meetings and then doing a wet lab and then showing how to do it correctly. And then I think, so you would be using a cutter from the pars plana and you irrigate from the anterior chamber. So you only need two instruments there. I think that's quite doable. If it falls down, then leave it, because but maybe it doesn't fall down, because if you take away the traction with viscoelastic, one could support the remnants of the capsule there and then complete the phaco and stick your 3-piece IOL on the CCC. So yes, very, very instructive. Thank you, Dr. Basavada.
Well, thank you, Shakon. Thank you for coming. What I would like to suggest to the delegates or the attendees who are listening to this webinar is that please remember what Shakon said just now. Live it, bye-bye. Do not chase. Your objective is not anyhow to fish that material out and send it to KMN, send it to Jakarta Center, send it to anywhere you want to send, but have co-management and understand the limitations of cataract surgeon. And on that note, Shakon also addressed that you need to go through the process of learning before you do vitrectomy, but that applies even to limbal vitrectomy. You must understand when you remove the vitreous, whichever way you remove, what can happen to the back of the eye, which you don't attend or don't you even have a better understanding. So
yes,
the time has come now to co-manage with retinal colleagues, respect them, and don't hesitate, no ego, learn from these masters. Shakon, thank you so very much.
Thank you, Dr. Visavada.
So
Thank you.
I'm done. Thank you.
Thank you, Abe. So, there's some message that I can pass to all the anterior surgeon that once you got the posterior capsular rupture, so just try to close the rupture with dispersive OVD, and in this case, the best is still a viscoat, and then do the vitrectomy, not limbal anymore, but change to the pars plana, and also using triamcinolone to help the visualization, and the setting of the vitrector is the cut IA, so we don't pull the vitreous, but we cut it first and then we aspirate. And also remember always to set the perimeter as low as you can. So we will continue to Dr. Suharnila. Dr. Suharnila, please, she will show some videos.
Ya, terima kasih Dr. Hadi. Selamat malam teman-teman sejawat semua. Malam ini kita coba akan lihat video bersama-sama dan mencari faktor-faktor apa kira-kira yang bisa menyebabkan nukleus drop. Ya, video silakan play. Ya. Pada kasus ini dari awal kita melihat permasalahan adalah hard cataract, kemudian sisi-sisinya yang terlalu kecil, kemudian kesulitan untuk memutar lensa. Stop video. Ya. Jadi kalau kita lihat di sini ada hard cataract, sebaiknya kita tidak melakukan sisi-sisi yang sekecil ini. Kita butuh sisi-sisi yang lebih lebar karena kita butuh enough space untuk melakukan cracking pada nukleus yang sangat keras. Dengan sisi-sisi sekecil ini tentunya nanti ke depannya proses vakuumulsifikasi akan menjadi sangat sulit. Dan kemudian kalau rotasi tidak bisa kita lakukan, jangan dipaksakan dengan satu instrumen seperti ini. Kita bisa melakukan hidrodiseksi kembali, hidrodiseksi ulang, tetapi dengan gentle, dan coba rotasi dengan dua instrumen di atas permukaan lensa dengan tekanan yang sama. Seperti waktu kita menyetir mobil, kalau kita memutar dengan satu tangan tentunya berat, tetapi kalau kita putar setir mobil itu dengan dua tangan itu akan lebih ringan dan ada kekuatan yang lebih besar untuk memutar nukleus. Kalau seandainya rotasi ini tetap tidak berhasil, kita bisa lakukan grooving yang cukup dalam dan panjang, kemudian coba lakukan cracking untuk membelah lensa. Biasanya dengan seperti ini air akan masuk di bawah di bawah lensa dan bisa lebih mudah diputar. Kemudian kita pakai chopper masuk ke dalam trench, menempel di dinding vertikal dari trench yang kita buat untuk kita merotasi nukleus tersebut. Ya, play. Nah, pada kasus ini sudah dilakukan grooving, tetapi kita lihat tidak cukup dalam dan agak sulit untuk melakukan cracking. Kita lihat bahwa vekotipnya juga sedikit sekali yang keluar dari sleeve-nya, sehingga ketika melakukan chop juga tidak bisa masuk dengan cukup kuat dan tidak bisa memegang lensa dengan kuat, dan akhirnya cracking sulit dilakukan. Kita lihat ada penekanan-penekanan yang terlalu kuat ke dalam, dan kemudian kita lihat bahwa terjadi robekan di sisi anteriornya. Robekan seperti ini bisa terus berlanjut ke kapsul posterior dan kita lihat lensa mulai tumbling. Di sini surgeon mulai berusaha untuk melakukan melanjutkan dengan ECCE, tetapi karena lihat tadi vitreous sudah prolaps, maka tidak dilanjutkan dan kemudian dilakukan dengan pars plana. Tetapi kalau misalnya tidak ada retinal surgeon di sekitar kita dan lensa belum betul-betul drop seperti tadi, seandainya kita mau convert ke ECCE, maka lebih baik jangan melebarkan clear corneal incision kita, karena dengan clear corneal incision dilebarkan, nantinya kita akan mendapatkan high astigmatisme post operasi. Jadi akan lebih baik kalau kita alihkan insisi kita di bagian superior. Jadi limbal insisi di bagian superior. Dan kalau misalnya anestesinya masih topikal, mungkin lebih baik diberikan subtenon, kemudian main incision ditutup, dijahit, dan kita pindah ke atas. Dan seperti tadi dikatakan bahwa seandainya nukleus mulai drop ke vitreous, jangan pernah sekali-kali untuk mengejar nukleus tersebut dengan lens loop dan kemudian menariknya keluar, karena nantinya akan terjadi vitreous traction dan kemudian terjadi robekan retina. Video kedua. Play, please. Pada kasus yang kedua ini adalah white cataract. Kita lihat ada kesulitan kembali untuk memutarnya dan kemudian surgeon berusaha untuk melakukan hidrodiseksi ulang dan tampak berlebihan sangat kuat kita sehingga pupil melebar dengan cepat, dan kita lihat di sini ketika vekotip masuk dengan botol yang cukup tinggi, tekanan 50, mungkin botol sekitar 80, itu akan menyebabkan tekanan yang begitu kuat dan akhirnya terjadi rupture di belakang. Ini masih diusahakan oleh operator untuk memegang, untuk hold lensanya untuk dimakan, tetapi akhirnya nukleusnya drop. Ya, jadi pada white cataract sebaiknya kita tidak melakukan hidrodiseksi, apalagi hidrodiseksi yang sangat kuat seperti itu. Dan ketika vekotip kita masuk, mungkin sebaiknya kita mulai dari botol yang sangat rendah, 30-40, kemudian bisa ditingkatkan perlahan-lahan bila kita membutuhkannya. Pada kasus seperti ini, kita lihat sisi anteriornya masih cukup intak, maka kita bisa meletakkan IUL di sulcus, tapi jangan lupa jangan memakai IUL yang single piece, tetapi harus three piece supaya tidak induce glaukoma nantinya. Dan tentunya ini kita harus serahkan ke retinal surgeon untuk dilanjutkan operasinya. Terima kasih.
Terima kasih, Dr. Nila. Dr. Nila have shown 2 videos about the nucleus drop. In the first video, I saw that the surgeon, when trying to crack the nucleus, had put too much effort and power to force it. And I think that's one of the cause of the capsule rupture. Probably Dr. Abai or Shail will give any comment on those videos.
So first of all, hi to everybody in Indonesia. And I think the only place where we have seen harder cataracts than India is Indonesia. So I think you have much more experience with the worst and the hardest of the cataracts. So the first cataract, I think, was a nightmare for anybody who would have done it. It was a really rock hard cataract. To start with, I think the rhexis, for a cataract like that size of a cataract, it's a good idea to, like, we did a small rhexis in the beginning, but maybe before we start a phaco, to extend that rhexis all around and have an adequate space, because it will involve a lot of chop maneuvers, and to have a lot of space where you can easily occlude and easily chop. The other thing that I would probably not do in a hard cataract or a mature cataract is a hydrodissection, because first of all, the space is a little less, and especially with the capsulorhexis of that size, you can get really occluded because of the build-up of pressure inside the bag. So I would avoid any hydro. I would probably try and make a first crack and then try and rotate, and if it doesn't rotate, then probably go ahead and do a hydro, rather than doing a hydro in the first place. So I think that is one thing. The other thing, important thing is, for a black cataract, it's a good idea to chop a cataract rather than try a division technique, because there is very less space in the bag. And if you try and push 2 quadrants away, you're going to cause a lot of zonular stretch. So I think a direct chop, either preferably a horizontal chop, would be a good idea, because it will involve less maneuvers and less space consumption when breaking the cataract.
Yeah, I think I agree that in the first video, it was the small rhexis which split and then went around to cause a PCR. So if you have a small rhexis, and particularly if you have hooked it up, I think as surgeons, we should be very careful. And here the movement of the phaco tip and the amount of energy. sometimes too much manipulation and excessive use of ultrasound continuously can also lead to these kind of splits. So be a little careful. And I think, like Samresh said, I would not rotate the nucleus until I get a division, because then at least we have a plane between the lens and the posterior capsule. Sometimes these white cataracts may have a posterior polar component to them also, which you have never seen before because the patient came to you with a white cataract. So doing a hydrodissection is not a great idea, but I think the way it was managed is very good. And particularly one point, in any white cataract or where you cannot see the posterior capsule, if you want to come out, your phaco is done or your rhexis is done, always inject viscoelastic from the side port and then come out, because you cannot see the status of the posterior capsule. You don't know what is happening. So I think as a habit, you cannot do this when you are in a complication. So make it a habit for every white cataract, for every really, really hard cataract. Every time you come out, inject OVD and then bring out any instrument or your phaco probe.
I think for the second case also, good idea would be to peep into the other eye, because if it is a polar cataract or if the eye has undergone a surgery elsewhere and has a lens lying in the sulcus or badly placed lens, then probably it will give a clue that that white cataract in the other eye has a polar component hanging behind it, because sometimes posterior polar cataracts in mature form we will never be able to find out, and these are the cases that generally drop, and without with the least maneuvers, the moment we enter the eye we realize the entire nucleus is dropping down. And sometimes there's no way to find out, but maybe the other eye, looking at the other eye, can help a lot in that case.
Thank you. I think that's a great idea that when dealing with white cataract or black cataract, probably it would be better if we do OCT or probably a B scan, just to make sure that there are no polar or posterior polar or posterior plaque that will make the surgery become nightmare to us. Okay, and then I will continue the program with, I will present actually to video, but due to the shortage of time, I will only present one video on heart cataract, and then will be continued by Dr. Ricky, and then I will also present again, and then Dr. Nila, and then myself. Okay, first video. This is a white, and actually not really white. It's a brunescent cataract inside, and a very, very hard and leathery. So in such a case, video, okay. In such a case, what is important is when you're doing the grooving, do not do in a rush. So please don't push the tip forward and downward. So just slowly move forward like this. And of course, the power should be high enough to overcome the hardness of the cataract. And what I'll show here is I made the trans very deep, not too long, because if you make a deep, long trans, it will end up with the posterior capsule at the peripheral part of the lens. And then I do like what Dr. Samar says, that doing the cracking bit by bit. So we can see here, I cut it. In this case, I prefer doing the vertical chop because I cannot see if I put the chopper on the equator, it is not visible. So sometimes it makes me a little bit scared. So I do it vertical chop, but I make it step by step like this. And I think it will be much more safer than if we try to forceful it, to crack it at once. And then, of course, I will remind us, in such a hard case like this, please refill the OVD repeatedly, because the phaco procedure will take a little bit long time. So the turbulence will wipe out all the OVD that may protect the endothelial cells. So always repeated refill the OVD. And that's what I want to show you. Any comment, please?
Hadi, this was a great exhibition of cool, very cool. Your skill was coming out so well, Hadi. I think I've not been to KMN for a long time. I need to visit you again to learn a few more tips from you guys, actually. I'm rotting. So thank you so much. Can I request Vaishali now to show her presentation on our dense cataract? So
Of course.
We can go on to the next one, please.
So thank you, everybody. And on behalf of everybody of us at Raghudeep Eye Hospital, I would just like to show the way we like to deal with dense cataract. And I think, like Dr. Hadi showed and highlighted very well, that once you have a divided nucleus, whatever technique you use, then I think 60 to 70% of your job is already done. So I will just show a couple of techniques that we find very useful, particularly in dense cataracts, to divide the nucleus completely, so that then it becomes easy. So there are broadly, we like to do chop techniques for the hard cataracts, and there are two kinds of chop. One is the direct chop, which was originally described by Dr. Nagahara. And then there are lots of modifications of the vertical chop or the stop and chop technique. One of the modifications which we all learned from my father and we all use is the step-by-step chop in situ technique. And this is very useful in all grades of hard cataract, even for modest cataracts. So I'll just show you the animation. So what this technique involves is basically you take your phaco tip and you occlude it at about the junction of 1/3 upper and lower 2/3 of a deep trench. You need a small central trench. Like you can see here, this is the rhexis margin, the green one. And the trench is within the rhexis. So you don't need a very long trench. That also saves a lot of ultrasound energy. So your CDE or your phaco energy used will also come down. Now you occlude it at the level of top 1/3 and bottom 2/3. And then place your chopper. Now this chopper is a blunt chopper. It is more like a modified Sinski hook rather than a very sharp tipped chopper. So you are not worried about any injury to the capsule or to the equator or the lens material. And then raise your vacuum. Use a really high vacuum. This could be 350, 400, it could be 600, depending on the density of the cataract. Place the chopper, place the chopper just in front of and to the left of the phaco tip, and then make a chop. Then try to slowly divide it. So you will see here that we are not trying to immediately have a crack that goes through and through. So slowly we are dividing. Now you rotate the nucleus. And here again you use the tip of the chopper as a fulcrum. Rotate your wrist. You don't need to do this movement. And create a chop and then just separate it from periphery to center and from superficial to deep. Again, this is just to highlight what we are saying, and make as many fragments as you are comfortable with. It could be 4 fragments, it could be 6, it could be 8. There is no limit, but try to make as many small fragments as you can. And these should all be separated at the center so that they are easily removed like pies of a pizza. Now this is an old video, but this really highlights very well what is happening. Now the phaco tip, you can see here that this is the rhexis margin. So it's a small but deep trench. It is occluded. The chopper is placed and just a small chop is initiated. And now within that groove, without moving the phaco probe. It's not a bilateral movement, it's just a one hand like this. So notice that it is a movement at the wrist that should happen. And you slowly divide the nucleus. And I think Dr. Hadi highlighted this point very, very well, that don't be in a hurry or don't do too much stress. So I think there's nothing very much new I'm saying. I'm just highlighting what Dr. Hadi said. And this is a slit attachment which helps us to see the depth at which we are working. The chopper also does not go beyond the equator, so there is no blind maneuver happening here, which is the best part about this technique. So even if you had a small pupil, this technique comes in very handy, and we are trying to separate. Like I said, this technique can be used in all kinds of situations, particularly in small pupils, where I would be very scared in going across the equator or doing a long trench in this small pupil, because the iris you can see is almost tattered before the surgery itself. So this technique comes in very handy, even in these cataracts. But I think at this point I would stop and acknowledge the work from Dr. Shetal Raj, one of our colleagues at Raghudeep Eye Hospital in the past. And she and my father, they actually thought about this, that despite all your attempts, sometimes there are cataracts which will just not divide with divide and conquer, or with a stop and chop, or with a horizontal chop. So then what do you do? In these cases, we do what we call the multi-level chop technique. So here what is done is, first the probe is occluded superficially and a crack is created. You are not aiming to go to the bottom. So you do as much separation as is possible at this level. But this vacuum hole, which is so much at the top, and these lenses are usually 4 millimeter thick. Now if you do too much separation, as you can see, you can rock the zonules here. So you don't do that. You create as much crack as you can. Then you take out the phaco tip and you re-occlude. You go in the bottom of the crack again. So then you have a localized vacuum seal again. So the point is, first of all, we are trying to create as many pies or fragments as we can without trying to separate the bottom. So this is what we are seeing here. A first separation, then re-occlude the probe at a depth. So at this point, let's say in the beginning, if I start a vacuum of 700, maybe I come down to 500. So I'm not worried about the posterior capsule, but I go really deep and then use the vacuum hold there to create the chop. Because if we remember the physics of any chop technique, it is purely dependent on the vacuum seal that you create. Now in these big lenses, if you have a vacuum here, it's not going to be effective here. So you have to go down again, and then in multiple steps you chop that. So yes, it does take time, it is a little tedious, but I think it is worth the effort. So here is a clinical example of the same. As you can see here, really brown-black cataract, and there is no way that in one chop we are being able to separate this cataract. So an effort is made to do as much separation as possible without too much zonular stress. Then again the probe is occluded at a deeper level in the same fragment. And now you take your probe, chopper also deeper, and you just separate without moving the phaco probe. So I think this technique comes in very, very useful, particularly for that central flower petal that will just not separate. Now, another point about the direct chop or the horizontal chop, and all of us are finding more and more that if it's a really hard cataract, this technique is going to be very useful. So we don't create any central sculpting. That way you save on energy. You go directly with a very high vacuum, possibly the highest that your machine can give, and start at the center of the nucleus and go beyond, occlude. Now take your blunt chopper across the equator and move it. So do a horizontal chop. So you can see that this chop is very, very effective, sometimes more effective even than the vertical chop techniques. So if it's a very brown or a blackish cataract, you might want to do this technique. There's no harm in switching your technique. So you should be comfortable with both kinds of technique. There is no only one way of dividing a nucleus. And here also you can do multi-level. So as you saw, again the probe has been occluded at a deeper level and then the horizontal chop is taking place. So we find this technique also very useful. And like I said, it saves a lot of the grooving energy. So your endothelium is much better protected as well. End point of whatever technique you use is to create as many small fragments as you can, like Dr. Hadi showed very beautifully. And just one point, again, Dr. Hadi brought this out very well. And if you saw, his bevel was always sideways and even little down. So basically, we are trying to confine the removal of the nuclear fragments away from the endothelium as much far as you can, because endothelium injury can occur because of the mechanical impact and so much of the heat generated with ultrasound. And this is just an OCT to show what happens if you do it at an anterior plane. This is just to sort of make us realize much better. And this is where you do it away from the endothelium. You can see this more for a teaching purpose and to realize. And when you remove these fragments, again, if they are small and divided at the center, they are much easier to remove and to eat up. And use high energy, high vacuum, but also keep supplementing dispersive viscoelastic. Again, Dr. Hadi brought this out very well, and you can see this in this video, so I won't take much time. And this is what we all want our corneas to look like on day one, and I think this technique helps here. Now, just one last video for a soft cataract. I think hard cataracts are difficult, but equally difficult are soft ones. But I think let's, with the time constraint, let me stop sharing my screen. And we go back, and if we have time, we can always come back to the soft cataract. Thank you.
Thank you very much. Very nice. I think we will continue since the next topic by Dr. Ricky will be more likely the same. So we will skip to the topic high myopia by Dr. Ricky. Dr. Ricky, please.
Ya, terima kasih Dr. Hadi. So we move to the high myopic eyes. Oke, langsung putar aja videonya. Pada video berikut ini sebetulnya tentang miopia yang tinggi di mana orangnya itu sensitif. Mana ini adalah bagian sebetulnya mata kedua, di mana mata pertama yang saya lakukan dengan IOP yang 30 saja, pasien itu merasa tidak enak, itu merasa sedikit kesakitan. Sehingga saya coba turunkan menjadi berkisar antara 20 sampai maksimal 28. Tapi problem di sini itu adalah chambernya itu yang begitu dalam walaupun sebetulnya IOP-nya yang rendah. Nah, untuk tips yang terbaik di sini itu adalah yang paling pertama kita harus perhatikan itu adalah wound construction yang harus baik. Dalam ini adalah main incision dan secondary incision itu harus betul-betul perfect dibuatnya. Kita lihat di sini juga bahwa hand movement itu, maksud saya movement dari hand piece itu ya harus betul-betul dijaga dengan baik agar tidak menyebabkan hambatan pada irigasi, di mana jangan terlalu swing ke kiri ke kanan sehingga juga di samping irigasinya itu terjaga dengan baik dan juga pada luka itu tidak terjadi kebocoran. So, bagaimana cara kita mempertahankan supaya posisi itu tetap baik? Pastikan bahwa phaco-tip itu jangan mengejar ke kiri ke kanan atau ke dalam ke atas, nah itu akan sangat berbahaya. Itu kita jangan dive ya, itu tidak baik. Nah, lakukanlah hal-hal yang seperti ini, itu semua gerakan yang mengambil, lihat perhatikan di gambar di film ini, gerakan yang mengambil itu usahakan tangan kiri yang menyuapin ke kiri atau yang lebih aktif, supaya tangan kanan itu tidak menyebabkan adanya kinking atau sumbatan pada aliran baik yang masuk maupun yang keluar. Sehingga pada pengambilan awal mungkin kita bisa bantu dengan chopper, tetapi berikutnya sebaiknya kita bantu aja dengan kanul atau spatula, dan maka kalau memungkinkan sekali bahwa kita pakai substitusi dengan kanula yang berisi OVD, sehingga kita lakukan untuk penggantian cairan di belakang supaya tidak terjadi kolaps di mana tekanan yang begitu rendah memudahkan kapsul posterior itu akan naik. Dengan kita melakukan pengisian atau dengan substitusi viskoelastik di belakang ini, maka di samping kita tujuannya untuk mensubstitusi cairan, kita juga memisahkan kapsul posterior yaitu ke belakang. Nah, untuk mempermudah dan mempercepat aspirasi pada IOP yang rendah ini dengan vakum yang begitu juga rendah tadi seperti terlihat di situ, di mana bantu perkecil atau hancurkan materi yang tersisa itu dengan menggesek-gesek itu pada permukaan lubang aspirasi dengan bantuan spatula yang kita pakai. Oke, sebetulnya itu tipsnya aja. Oke, terima kasih banyak.
Terima kasih Dr. Ricky. Dr. Ricky was showing to us that how he handled high myopic cataract in a very sensitive person. So he lowered the parameter, the IOP, to the bottom, the maximum that we can do it. And also you use so much OVD to facilitate the surgery. Look, Abe, do you have any comment in this case?
I think that Ricky did it very well. Just same points that these eyes globes are very compliant. So inflation and deflation is very common. So do not have too much of a bottle height and do not have a very high flow rate. So input and output should be at a lower level, balancing it. And sometimes the fluid goes behind the pupil, and if that happens, the pupil will come forward and the chamber will collapse. Pupil will dilate and become small. So put a spatula or a phaco probe or any instrument, lift the iris and let the fluid which is trapped behind the iris come in front so that the chamber deepens and the pupils dilate. So apart from that, that's very, very nice. Well done.
Thank you. And I will continue with the next video. I will bring this subluxated cataract and how I handled it. As we can see here, this is a subluxated lens that actually I was just aware when this patient was laid down in the OR. So during the examination in the office, I didn't know that there was a subluxation. So we can see at the left side, there is we can see at the left side here, this gold half like golden ring. Usually this is just a sign that just next door to this slide, there is a zonal loss like this here. Okay, and then so in this case, look, when I insert the OVD, it's stop. The lens moved back, and then when I try to make the first punch, you can see here that the enterocapsular wrinkle, this wrinkle is caused by the loose tension of the enterocapsule due to some zonal loss, so that the rest zonule cannot maintain the stiffness of the enterocapsule. So in this case, don't push or don't force to make the first punch by the utrata forceps, because if we make more force to push it, it may harm the rest of the zonule. So what I made here is I changed with a sharp needle to make the first cut, and then afterward we can continue with utrata. In this case, I made the CCC a little bit small, since I want to use this iris hook to lift and hold the whole lens during the phacoemulsification process. As we know, once we insert the phaco tip and start the process, once we push the pedal on first position, the irrigation force will push the whole lens backward. So in such zonal loss, it will end up with the whole lens drop to the vitreous cavity. So what I want to do is I put this iris hook, not at the iris, but at the capsule, like this, and to facilitate the hook to catch the Rexy stream, I put some OVD to make a space between the capsule and the cortex. And then I did the hydrodissection in a normal way, and then tried to rotate the lens. Then I insert the CTR. So there are some controversies in this situation. Many surgeons propose to put the CTR after the phaco, but in my opinion, I would feel much more secure if I put the CTR before I do the phaco, because once some part of the nucleus had been emulsified with the phaco, the capsule will collapse due to the absence of some zonal. So by putting the CTR inside the back, it will maintain the capsular back integrity and shape. It will still circular shape. Then it won't collapse when I do the phaco. So because I'm afraid that once it collapse at the point of the zonal loss, the capsule will come to the phaco tip, kissing the phaco tip, and I got the PCR. That's why. But the downside of this maneuver, I mean putting the CTR before the phaco, is like this. We have we got the difficulties in trying to remove the cortex. So instead of pulling the cortex to the central of the globe, of the back, we can also try to pull the cortex along the curve of the CTR toward the opening of the CTR. So, and then the IOL implantation, we can do it in a normal fashion, and then I tried to take the hook out of the eye and then center the lens, then it's done. Thank you. Any comment from Dr. Samaras or Abai?
Yeah, I think, Hadi, you showed the the principles of managing subluxation, and that is with all the stabilization instruments, puncture it, and the capsular retractors are good, but I use, like you, iris retractors only. I use Greischeber. I don't need, I don't use the capsule stabilizing hooks because they're very bulky and they need a bigger incision. I do not put in the capsule ring with this bulk inside because I struggle. I find difficult to put it, but if you can and you're doing it regularly, it's a better idea. There's no question about it. But I do a little later on when the bag is a little bit evacuated. And for cortex removal, I do fluid and viscodissection, both. So that will create a space and will ease the cortex removal. But that was a wonderful video showing all the important points in removing subluxated lens. Thank you. I think we can move on further down.
Yes, okay. Dr. Suharnila. Please, Dr.
Ya.
Suharnila. Yeah.
Ya, terima kasih dok. Saya mau sharing mengenai penanganan posterior polar katarak. Seringkali posterior polar katarak menjadi tantangan ya buat dokter mata karena kemungkinan risiko robeknya kapsul posterior sangat besar. Saya akan menggunakan inside out teknik dari Dr. Fasafada. Ya, silakan play. Jadi rule number 1 adalah no hydrodissection. Jadi jangan lakukan hydrodisseksi karena air yang masuk di bawah kapsul itu akan langsung merobek kapsul posterior. Yang bisa kita lakukan adalah langsung melakukan grooving seperti ini yang cukup lebar supaya kita bisa dan cukup dalam supaya kita bisa lihat lapis demi lapis dari lensa tersebut sehingga ketika kita melakukan hidrodelineasi itu kita tahu jelas di mana kita masuk. Dan kemudian nukleus kita bisa emulsified, apabila nukleusnya keras kita masih bisa lakukan rotasi, tetapi ingat harus betul-betul nukleusnya sudah lepas dari korteks. Kemudian untuk mengambil korteksnya, saya lebih suka melakukan viskodiseksi. Jadi lakukan viskodiseksi sekeliling korteks itu 360 derajat, baru kemudian terakhir di bagian sentral yang kita lakukan VECO. Supaya kalau seandainya terjadi posterior capsule rupture, paling tidak di sekitar di sekeliling itu sudah bersih. Dan jangan lupa di setiap step ketika kita mau mengeluarkan VECO tip, kita harus betul-betul memberikan viskoelastik terlebih dahulu supaya kapsul posterior tidak naik ke atas. Karena seringkali kapsul posteriornya naik pada saat itu terjadi PCR. Apabila terjadi masih ada sisa kekeruhan di kapsul posterior, juga jangan terlalu agresif untuk membersihkan karena biasanya pada posterior polar katarak ini kapsul posteriornya memang benar-benar rapuh. Mungkin akan lebih baik kalau nanti post-op kita bisa lakukan YEG laser daripada kita membuat robek posterior kapsulnya. Ya, demikian insight of teknik yang biasa membuat kita jadi bisa lebih aman untuk menangani posterior polar katarak. Terima kasih.
Thank you, Dr. Suharnila. Dr. Suharnila has shown Dr. Fasafada's technique for managing the posterior polar cataract. Any comment from you, Abhay or Dr. Samaras?
Samresh has a presentation. I think Samresh has a presentation on it. Samresh, go ahead.
So, Dr. Suharnila, that was a very good demonstration of the inside-out delineation technique. And you brought about some very key points. I'm just going to cover up the same thing with a little more detail. So the first pearl, posterior polar cataract is a complex cataract. So it's not for, the early surgeons. But if you keep these things in mind, it can become a very safe technique. The idea is to not build up pressure inside the capsule margin, just like we were discussing in a mature cataract, because we don't know, and this capsule is weak, so it can open up. So we don't want to build up hydraulic pressure. So how do we do that? The first thing we don't want to do is do a normal hydrodissection that we do in a routine cataract, because for sure the rupture is going to be very high with this sort of a hydrodissection technique. So what do we do? The idea for a posterior polar cataract, for us, the biggest problem is to take out that nucleus first, because we fear the nucleus to drop down when the capsule ruptures. So we want to create a cushion between the nucleus and the posterior capsule. And what is that cushion? That cushion is the epinucleus cortex complex, because that will protect the capsule, posterior capsule, and keep it away. A good way to do, if you do conventional hydrodelineation, which is just putting your irrigation cannula inside the nucleus, some part of the fluid can find its way under the capsule, and you can land up with an inadvertent hydrodissection, and you can land up with a posterior capsule rupture. So a conventional hydrodelineation that we have learned may necessarily not work all the time for a posterior polar cataract. This is Dr. Fasafada's technique that was published many years ago of inside-out delineation that Dr. Suharnila brought about so beautifully. The idea is to first form a shallow trench and then use the wall of the to do a hydrodelineation. Because you're injecting inside the nuclear material, the chances of it finding its way outside is very low, and it will only delineate the nucleus from the epinucleus area. So not too much pressure will build up inside, and the fluid will not go under the capsule behind the posterior capsule area and cause a rupture. And this is the classical inside out technique. Just to demonstrate it in a clinical scenario, notice after we've done a trench, a moderate density trench, we use these cannulas. This is a right bent cannula. We bury inside the nuclear material and we slowly inject fluid, and notice how the nucleus gets completely delineated away from the epinuclear area on the right side, and you repeat the same thing on the left side to cause a complete cleavage between the nucleus and the epinucleus plane. Now that you've done that, what do you want to do? You don't want the entire capsule bag complex to move in front, because the moment it moves in front and then it goes back, the posterior capsule, which is weak, can give away. So for this, one needs to maintain a closed chamber at all points in time during the surgery. One thing that you want to do is never take out your phaco probe and always inject an OVD, like a dispersive OVD or viscoat, before pulling out your phaco probe after doing the first trench, because that's very important to maintain the chamber. And then go ahead and do an inside out technique. The second thing you want to use is a bimanual irrigation aspiration over a conventional coaxial one, because in a bimanual irrigation, the chamber is maintained, the main incision is completely shut, and the chance of having any prolapse or any fluid leakage is minimal. Bimanual also gives you the dexterity. Like you saw with Dr. Hadi's video, there was getting the cortex on the right side of the incision was a little difficult. And so using a bimanual incision technique will be a good idea to capture that part of the cortex as well. The next most important pearl is, once you have done a hydrodelineation before, and when you're trying to remove the nucleus, and after you remove the nucleus using phaco, to form some sort of communication between the anterior and posterior compartment. So there is controlled but limited release of fluid that causes that wave to pass slowly and causes a cleavage in the posterior polar area. Once you remove the nucleus, with low parameters, as you notice over here, we are just trying to catch that epinuclear bole and dissect it centrally. We're not attempting to remove it right then and there, but just to hold it with adequate vacuum and dissect it central. And once we have debulbed, now we go ahead and very gentle hydrodissection that we are doing right now to let that fluid slowly pass in the area of posterior polar cataract. Once the nucleus is out, there is enough space for the epinuclear complex to move. And so once you create a cleavage plane, the fluid can gently dissect it out rather than pushing the posterior capsule backwards and causing a rupture. And once you remove the nucleus, you can go ahead, and if you're finding it difficult to remove epinucleus, to do a gentle hydrodissection at that point in time. So this is a classical inside out. This is just to show you, this is a posterior polar cataract with a ruptured capsule. This is on a femto technique, but that's not the point of discussion over here. What I wanted to bring about is that when you put in a femto cataract, you don't need to do a hydro maneuver at all, because you can use the edges of the femtosecond to grasp the nucleus and cause a dissection. So notice how with these rings, we are able to gently tease out this whole nuclear area. So in a femto, you don't really need hydro maneuver. But once you have the nucleus out, the technique is essentially the same. Use the sharp edges of the epinucleus, occlude them, and try to tease them out centrally so that you find a cleavage point like over here, so that the fluid can find its way behind the epinucleus and cause a gentle but controlled removal of the or separation between the posterior polar cataract and the posterior capsule. Now, mind you, this patient has an open posterior capsule because there is a pre-existing rupture. Again, do a viscoelastic exchange. Always inject dispersive viscoelastic before pulling out your instruments. And the use of bimanual irrigation aspiration has a certain advantage, particularly in this cataract, because you can access more area more elegantly. But the best part about using these control techniques like inside out and maybe using a femto is the fact that your posterior capsule, even though it is ruptured, does not generally extend, because it's a very, very controlled low parameter surgery. And if you can convert this small ragged posterior capsule tear into a continuous posterior capsular axis, so here we are using a bimanual microincision forceps to pick up that posterior capsule tear and convert it into a posterior capsular axis margin. You will get a very strong posterior capsule tear. It's sometimes, it's once you've done a good surgery and you want to implant a good lens in the patient's eye, the only fear becomes what will happen when I put a lens and the posterior capsule opens up like a zipper. But this will not happen if you create a nice posterior rounded capsular axis by grasping and re-grasping again and again. You just need to have a rounded margin. Needless to say, once you have an open posterior capsule, there are a high chance that vitreous has prolapsed. Always a good idea, if a posterior polar ruptures, to use all principles of vitrectomy, stay in the posterior capsule. Now here we are doing a limbal vitrectomy, not a pars plana, and we are doing that because we know, first of all, that margins are circular and it's not going to extend because circular margins are very strong margins. And we were able to implant a high astigmatism toric IOL in this patient, which we had promised or committed to the patient that if things go well, we will be able to implant this lens in the patient's eye, even though this patient had an open posterior capsule, because generally with the principles of closed chamber technique, inside out delineation or a femto delineation, and following this right, chances are you will be able to save the bag even if the posterior capsule ruptures, convert that ragged tear into a continuous rhexis, and have a good central placement even of a premium IOL in this patient. And I think that's very important to understand that, if you get the principles right, you can have a very good stable eye. But just to show you, posterior polar cataract is not over until you've removed the speculum. This is a patient where we did everything, and when we were finally hydrating the main incision, just to finish off the surgery in a posterior polar cataract, notice what happens. The capsule gives way just because of increased pressure inside the eye. So it's a weak capsule, and you have to be very, very careful, and only until the speculum is removed from the eye, the surgery is not over. I think this is it for posterior polar cataracts. Yeah.
Thank you. Abhay, there's a tricky question.
Yes, yes.
Since in posterior polar cataract, usually the cataract is quite not hard.
Yes.
So whenever we got the hard cataract with the posterior polar, could we still use this in and out technique?
Well, it depends. Obviously, if it is too hard, a kind of cataract you showed, only God may help. But if it is sufficiently, it is, what I say is that you have to try. So you make a trench and try to penetrate the vertical wall, and do not go very deep in the wall. Go as deep as you can. You will end up in a superficial level, and you will create a very thin layer of epinucleus.
Okay.
And then you need to do direct chop here, because if you try to separate, you can produce rupture or extend it already existing. And also try not to rotate very much. So that's another thing, that once you remove 1, 2, or 3 fragments by direct chop in that situation, then you can do hydro and visco dissection and try to bring very gentle rotation to the faculty. But these are very, very difficult scenario. I don't have a right answer for this, but I will keep trying delineation if I can. Yeah.
Thank you.
But one of those things, it's very difficult.
Thank you. The next video is, I will show what we titled here as a Morgagnian cataract, but actually is this not a classical Morgagnian cataract. What we want to show here, that as we know in Morgagnian cataract, usually the whole cortex and part of the nucleus was melting, and so we are dealing with a small nucleus. So for all my colleagues who are very familiar or always using the stop and chop technique, I think in this condition, you may or you have to change your technique with a direct chop of Nagara chop, like shown here. Because if we try to make like this, I try to make the trends, but the nucleus is moving. So instead of doing the stop and chop, I change to direct chop here, and it will work much better. And also the advantage in such a case is we can see the visibility of the equator was so good. So it's no doubt, or you don't have to be scary to deliver your chopper until the equator. So everything could be seen well. So this is just a simple example of how we deal with a small nucleus.
Excellent, excellent. Adi, you showed it very well. That I think I totally agree with you that direct chop is the way to go with these nucleus. Other thing is that because this nucleus is smaller than the bag, it keeps spinning into the bag. And you can reduce that spinning by two ways. One, by reducing the irrigation, because irrigation too much also will spin it up. And also you need to increase the flow rate. If you're using 25 cc flow rate, use 35 cc, and you did that very well. So lower bottle height, slightly raised aspiration flow rate than your normal setting, and direct chop, and sufficient energy in highest vacuum. And you showed it so elegantly. So I think this is it. Yeah.
Thank you. We still have two
yes.
very interesting videos. So I will ask Dr. Shakon to come up with the narrow angle glaucoma. It is very interesting case.
Oke, ini adalah pasien narrow angle yang waktu dilebarkan pupilnya, tolong di-play, tekanannya naik, ya, terjadi angle closure. Jadi ini kita masuk, kita lihat bahwa lensanya ke depan gitu. Saya dapat space sedikit dengan viskoelastik, seperti batu dia. Tetapi waktu saya angkat tepi itu irisnya, cairan bisa keluar dari belakang, bloknya hilang. Sehingga bisa dilakukan CCC. Andai kata tidak diturunin tekanan, itu langsung bakal lebar, robek, dan ruptur. Saya masukkan CTR karena saya lihat tepi dari kapsulnya itu kemungkinan ada gangguan dari zonulnya. Dan ya operasi bisa dijalankan dengan baik. Jadi mengangkat tepi dari pupil itu bisa mengeluarkan cairan, membebaskan. So basically lifting the edge of the pupil to release fluid trapped behind, it lowered the pressure. It would have been more wise, as Dr. Basabada said, to give mannitol before surgery, but I didn't do that, unfortunately. Thank you.
So I think this is a very, very important tip, Shakon, that you shared with us. A very simple maneuver and helps you tremendously. So I think, thank you so much. But a previous laser PI also would reduce the chance of that fluid trapped behind the iris. So if it is a known angle closure glaucoma, and if the PI can be done, it's a good idea. But you know, you need two procedures. So this trick, I think I'll keep in mind. I didn't have to do this until now, but I'll remember this. This is a very, very useful.
She refused PI, that's why.
Yeah, I agree. This is a very, very simple technique, but there's a nice demonstration how to handle such a difficult situation with just lifting the iris. So the last video will be black cataract with iris coloboma that will be presented by Dr. Bondan Harmani. Dr. Bondan, please.
Masih mute, Dr. Bondan.
Ya, oke. Selamat malam, Dr. Hadi. Stop dulu. Pasien ini pasien wanita, umur kira-kira 60 tahun, dengan kedua mata dengan koloboma iris. Jadi pupil itu letaknya di bawah sekali, di jam 6. Dan kemudian tampak katarak yang sudah black katarak. Kemudian waktu operasi saya mencoba untuk membuka iris lebih lebar karena dia kecil sekali di bawah. Tapi dengan pemberian epinefrin dan sudah diberikan mediatikum, dia tidak bisa juga lebar. Jadi dalam pikiran saya, tidak mungkin kita melakukan yang lain, teknik yang lain kecuali dengan ECCE. Ya, silakan video. Ya, kita lihat itu pupil itu ada di bawah sekali. Ya, mau saya buka tidak hanya seperempat dia membukanya. Jadi tidak mungkin kita mengeluarkan lensa yang hitam itu untuk bisa keluar. Jadi yang saya lakukan adalah pertama memberikan pewarnaan dulu dengan Trypan Blue. Kemudian saya lakukan iridotomi total iridotomi dari ujung jam 12 sampai ke bawah, sampai ke pupil. Sehingga terbuka sekarang, kita bisa lihat kapsulnya. Kemudian saya lakukan CCC dengan ya bisa dengan baik. Ya. Kemudian saya buka biasa untuk melakukan lensanya. Kita tampak bahwa lensa itu black cataract, ya, lensanya hitam. Nah, kemudian saya lakukan biasa untuk membersihkan korteks, tapi kita tahu di bawah sana itu zonula juga tidak ada di daerah situ. Ya. Jadi kami bisa pasang seripis IOL in the back, dan kemudian saya melakukan rekonstruksi dari irisnya. Saya harapkan bahwa pupil yang di bawah itu akan bisa ke sentral, sehingga dia akan melihat dengan sentral pupil di tengah. Ya, tidak di bawah seperti yang sebelum operasi kita lakukan. Pasiennya visusnya dari hand movement bisa menjadi 1 minggu menjadi 1/60. Kita harapkan dia bisa paling tidak bisa jalan sendiri ya. Sebelumnya itu dia dituntun. Jadi dengan terbukanya pupil di tengah ini dia bisa jalan, lakukan aktivitasnya dengan baik. Terima kasih Dr. Hadi.
Dr. Bondan, itu lensanya in the back?
In the back, ya. Yeah. In the back. Saya bisa masukkan in the back.
Okay. What
Bondan,
is very...
It was a very, very good concept. And I like the idea of converting into a full iridectomy thing. But more than that, you took care at the end of the surgery to do a pupilloplasty, which was even better than the original idea. And I would suggest that if you do pupilloplasty at both the ends of those two pillars, you will have shifted the original coloboma opening into the central portion of the visual axis. So you can do pupilloplasty at both the ends now that you have two pillars and bring that central. But you showed this concept of doing a total sphincterotomy and utilizing to your benefit, and then doing a pupilloplasty at the end. Excellent.
Thank you, Dr. Fasavada. It's also interesting to me that the way Bondan put the IOL in the back, and he put the both haptics on the left and the right side of the eye, because at the lower end, I mean in the inferior part, he doubt that there will be probably no zonule. So by putting the IOL in the back, but in a horizontal position, it would be more
more
secure. Safer. Okay.
Absolutely, absolutely.
Yeah.
Very good.
Thank you. I think we come to the end of the whole program. Thank you very much to our outstanding guest, Abai.
Thank you, thank you, thank you all.
Samares, yeah. Okay.
Thank you. I think I don't think we qualified to be a part of the host now after so many years. So I think as a family, the KMN and REH are working together, and I hope the attendee has liked the program. We enjoyed very much, and I hope the attendee also have enjoyed as much as we did. So once again, thank you all.
Thank you. Shakwan, probably you will give your closing mark for this evening.
Well, thank you so much to all KMN colleagues, especially thank you to the audio-visual people that have been working until midnight so many days editing these videos. Thank you to Dr. Vasavada and your family, your wonderful family, for sharing all your information here. Terima kasih kepada semua peserta webinar. Mohon maaf kalau jalannya agak lebih lama, tapi saya percaya bahwa kita semua mendapat banyak sekali hints yang bermanfaat. Semoga kita semua dilindungi oleh Tuhan Yang Maha Esa, kita tetap sehat dan tidak kena itu penyakit COVID. Terima kasih.
Amin, amin. Terima kasih. Semoga semuanya bermanfaat. Kita akhiri acara ini. Terima kasih. Sampai ketemu. Mudah-mudahan kita bisa ketemu lagi di acara webinar KMN.
Goodbye, my friends.
Bye-bye. Bye-bye.
Bye. Thank you, Dr. Vasavada and family.
Thank you, Dr. Vasavada.
Thank you, brother. Thank you, everybody.
Thank you.